Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOGS Endocrinology Committee. A warm welcome to all our respected faculty and dignitaries who are here for today's event. This is the first in a new series this year, 2023, the Experience Series, with the blessings of our seniors and our eminent faculty who are gathered here today. Today's program is on hypertensive disorders in pregnancy, and we have updated management strategies for all of you who've logged in, not only from India, from across the world. We have more than 800 registrations so far from more than 18 countries. So thank you very much for being here. Over the next couple of hours, we'll have very senior and eminent clinicians talking about the updated management strategies in hypertensive disorders in pregnancy. But before we begin, as is customary, next slide, please. I would like to place on record my gratitude. Next slide. To our AMOGS office bearers, Dr. Rajendra Singh Pardeshi, sir, who's the president of AMOGS. Next slide. To Dr. Sujata Dalvi, our secretary of AMOGS. The chairperson of ICOG, Dr. Lakshmi Shrikande, and the secretary of ICOG. Next slide. Dr. Ashok Kumar, they have granted us the ICOG credit point for this event. Thank you very much, sir and madam. Next slide, please. We have Dr. Sujata Dalvi, who is the secretary of AMOGS, and she will be here as a chairperson for today's event. We are delighted to welcome her. Next slide. Dr. Bharti Maheshwari is the past chair of the FOXY MTP committee, and she has done fantastic work during her tenure as chairperson of that committee. We are delighted to welcome her as a chairperson. Next slide. We have two fantastic speakers in the shape of Dr. Charmila from the South. She's the Vice President-elect of FOXY. Next slide. And Dr. Suchitra Pandit, madam, who's the past president of FOXY, Mumbai Society, and the Gestosis Organization in India. Thank you very much for joining us. Let me formally introduce Dr. Rajendra Singh Pardeshi, sir. Sir is the president of AMOGS. He served as the president of FOXY in the past. He was there with us throughout the pandemic, and he gave us a lot of support and encouragement when I did my series during the pandemic. He was there for almost every single program as a chairperson or a guest of honor or a chief guest for my events. Sir has the unique distinction of winning several prizes at ASCOG conferences. Over to you, sir.
Yes. Good afternoon, everybody. Respected ICOG chairperson, Dr. Lakshmi Srikande, ICOG secretary, Dr. Ashok Kumar, our AMOGS secretary, Dr. Sujata Dalvi, our past president, FOXY, Dr. Suchitra Pandit, and FOXY VP-elect, Dr. Charmila, and our ever-active chairperson, Dr. Pratik Tambe, and Bharti Maheshwari. As all known that SDP, preeclampsia, eclampsia contributes around 15 to 20% of maternal mortality. As you know, in 1990, the maternal mortality rate was around 560 per 1 lakh deliveries. WHO FIGO has given target of reducing MMR to less than 70 in 2030. But now India, MMR is 103. But I can say proudly, I can announce that our Maharashtra MMR is 38 now. I think this year, Pratik, it's reduced to 33. And now with the contribution of all our members, all our FOXians and AMOGsians, we can surely take a challenge to reduce to a single-digit number. And with two giant speakers, Dr. Suchitra Pandit and Dr. Charmila Ayyavoo, this will again help to reduce MMR. I congratulate Dr. Pratik Tambe, chairperson of our AMOGS Endocrinology Committee, for this continuous efforts. His continuous efforts to achieve, and I think this also helps to reach our MMR goal with these types of activities. I wish every success to this webinar. I wish every success to Dr. Bharti Maheshwari also for her future endeavor in FOXY.
Thank you.
Thank you so much for inviting me. Thank you so much.
Thank you very much, sir, for being here and for gracing the occasion. Thank you very much for your blessings, and we will need your blessings to continue in our efforts in the future of the series as well. To formally introduce Dr. Sujata Devi ma'am, she's a consultant OBGYN at several hospitals in South Mumbai. She's an honorary clinical associate at the Nauroji Wadia Maternity Hospital. As I already said, she's the secretary of AMOGS currently, and she's the joint assistant editor of Jogi, which is the Foxy journal. She's an office bearer of the Mumbai Society. We're delighted to have her here in person. Thank you so much, ma'am, for joining us. I would request you to introduce our first speaker of the day, Dr. Charmila.
Yeah.
Sana,
So
can we
thank
have
you,
the
Dr.
slide on
Pratik.
screen,
Sorry.
please?
Thank you, Dr. Pratik. I would just like to say a few sentences that on behalf of AMOGS, I would like to acknowledge the constant encouragement given by our president, Dr. Rajendra Singh Pardesi, and I would like to express gratitude to Dr. Pratik Tambe, being an AMOGS endocrine chairperson, committee chairperson, for giving me an opportunity to be involved in this session and being a chairperson for this session. Today's topic is HDP. However hard you talk and so much you talk, but HDP is always a very important topic so far as obstetrics is concerned, and it's the highest most cause for maternal mortality. And we have two excellent speakers for today, Dr. Charmila and Dr. Suchitra Pandit, who are expertise in their own field, and they would give us a good guideline so far as HDP is concerned. Our first speaker is Dr. Charmila Ayyavoo, and she is going to be speaking on hypertensive disorders, the changing landscape. Can I have Charmila's? Charmila is a vice president-elect of FOXY 2024. She was a chairperson of Clinical Research Committee of FOXY in 2016 and 18. She is an ICOG governor, ICOG Governing Council member 2021 to 22, and she is a national coordinator for UNICEF FOXY PCA as well as PG program. She has been national coordinator for ISA Gurukul 2022, and she has been a past secretary of Trichy OBGYN Society. So over to Dr. Charmila for her topic on hypertensive disorders, the changing landscape. Let us hear in from Dr. Charmila.
Thank you so much, Sujata ma'am, for that very kind introduction. I would like to pay my respects to Dr. Rajendra Singh Pardesi sir, who's a brother to me. He's guided me so much through the years. And like to welcome Dr. Bharati Mageshwari to the program, and special thanks to Dr. Pratik for giving me this opportunity to talk in AMOGS. Thank you so much for this opportunity. My talk is going to be on hypertensive disorders, the changing landscape. As both Sujata ma'am and Pardesi sir said, this disease is not going away from the obstetric scenario, and it's creating so much of havoc throughout in every part of obstetrics. So when you talk about the disorders, it's almost like it accounts for 14% of the global maternal deaths. It is the second leading cause, direct cause of maternal mortality after maternal hemorrhage. And when you talk about like how much it's prevalent in the community, it's, even though it's said it's 4.6%, I would say it's grossly underreported, because almost like 10% of the pregnant population is affected by these hypertensive disorders as far as India is concerned. So when you want to define this disease, whenever there's a blood pressure which is higher than 140 by 90 millimeters of mercury, and when it happens before 20 weeks of gestation, and there is no proteinuria, it is labeled as chronic hypertension. But suppose there's proteinuria even before 20 weeks of gestation, and there's a rise in blood pressure, or there's a maternal organ dysfunction, then it becomes superimposed preeclampsia on chronic hypertension. When this disease happens after 20 weeks of pregnancy, and there is no proteinuria, it is a new onset hypertension after 20 weeks, and it's labeled as gestational hypertension. But when there's at least one of the following, which can be proteinuria, maternal organ dysfunction, if there's a doubling of the liver enzymes, AST or ALT, the patient has got pulmonary edema, or even uteroplacental dysfunction at this point of time, it's labeled as preeclampsia. But there are certain other varieties which has been actually put up in the International Society for Study of Hypertensive Disorders in 2018, and that they brought in white coat hypertension and masked hypertension. White coat hypertension is one where you diagnose an increase in blood pressure in the office or clinic, but when the patient goes home, there's a normal domiciliary blood pressure recording that is around 135 by 85. But do not take this lightly, because these patients also have got a higher risk for going into preeclampsia or eclampsia later on. So they need to be put a watch on. And there's the other variety called as the masked hypertension, where you've got normal reading in the clinic, in the office, and even at home it will be normal. But when you put the patient on a 24-hour monitoring, you will find that the blood pressure is elevated at some point of time. And that is masked hypertension. These two are very important because these are ones which we miss usually, and the patient lands up with a complication later on. So these hypertensive disorders, that is one of the part of the changing landscape. You do not want to miss diagnosing white coat hypertension or masked hypertension, because you would have diagnosed preeclampsia, and when a complication happens, you will know. But the starting stages of these disorders, if you don't diagnose, it's going to cause complication. That's one changing landscape. And when we see the increasing incidence of this disease, it's almost increased by 25% in the United States, where there's a good documentation of this disease. And between 1987 to 2004, it's almost increased by 25%. And when you compare a lady who gave birth in 1980 and when she gave birth in 2003, there was almost a 6.7-fold increased risk of severity of preeclampsia, not even mild. The severe preeclampsia rate has increased almost 6.7-fold. And when you talk about the risk factors for these disease, we always talk about nulliparity, but remember primary paternity, the partner change will also cause this disease. And advanced maternal age is contributing to increased risk of this disease because mothers are getting married later, as well as previous preeclampsia is also contributing to a higher risk of preeclampsia in this pregnancy. The maternal corpulence, that is the higher body mass index of women now, is also contributing to a higher risk of preeclampsia. Higher risk of diabetes is there now, and so the other metabolic disorder, that is a cardiovascular component, also adds in and becomes preeclampsia during pregnancy. Multiple gestations because of infertility treatments is also contributing to a higher risk. Assisted reproductive technology, which is being used in so many cases now, is also contributing to a high risk of preeclampsia. And when the mother has a pre-existing medical condition, which seems to be much more common now because of the higher body mass index, diabetes, and advanced maternal age, they usually land up with pregnancy with chronic hypertension, or rarely they can have antiphospholipid antibody syndrome and renal disease too. So the prevalence of preeclampsia has got an increasing slope now. That the landscape has changed. And the factors which have contributed to this ascending trend of preeclampsia, according to the BMJ in 2013, is the use of assisted reproductive technology, the increased incidence of hypertension, diabetes, obesity in mothers, and also the early diagnosis problems, because you sometimes tend to miss the diagnosis in the earlier period, then the patient lands up with a complication later on. And these are all responsible for the ascending trend of preeclampsia prevalence now. And there's a difference in the economy also, which they found out now. Like in the high-income countries, the incidence has actually decreased, but in low-income countries, the incidence has actually increased. And the factors which has contributed to that, according to the 2018 article by Myron Kiss, the decreasing incidence in high-income countries is because of there's a good access to quality prenatal care. And when there's a patient who's got preeclampsia and eclampsia comes to the hospital, there's an adequate management which contributes to a decrease in incidence of the complications. But in low-income countries, the increase is probably because of reduced access to quality care and also because of the poor management of cases of preeclampsia and eclampsia. And the risk profile has also changed in the different countries. In developed countries, the incidence is more in low-risk nulliparous women because they pick up those high-risk cases quite early in primipara because the incidence is usually high there. And when they pick it up early, they manage it much more effectively. But when it happens in a multiparous women in a developed country, it's usually when they have a high-risk condition. So when they manage a high-risk condition better, these patients do not land up with severity of preeclampsia. And that is a change which has happened in developed countries, and it has not been seen in developing countries still. So when you define this disease, it's actually new onset hypertension, which arises after 20 weeks of gestation with multi-organ system development, and it should completely resolve at 12 weeks after birth. Proteinuria has been taken off from the definition of this disease now. So it's actually put up as multi-organ system involvement, because even without proteinuria, you can have the other organs getting involved, and that is also preeclampsia. So the changes in diagnostic criteria, the earlier criteria was a classical triad of hypertension, proteinuria, and edema, but now it is superseded with the definition of with hypertension and organ dysfunction, which can be renal, hepatic, hematological, neurological, or placental. And any of that organ dysfunction with hypertension is almost sufficient for a diagnosis. You do not need proteinuria or edema now, and that is a change which has happened in the diagnostic criteria. And proteinuria is not an essential condition. It's not a sine qua non condition to characterize preeclampsia as previously ensured. And the International Society for Studies on Gestational Hypertension, which was published in 2014 and again in 2018, reinforced the point that every hypertensive pregnant woman should be investigated for multiple organ involvement, even if she presents with negative proteinuria. So any patient, even if you think it's a mild hypertension, you will need to investigate for an organ involvement, even if proteinuria is not there. This approach is innovative, and it tends to encompass cases that are neglected by the absence of proteinuria. So the so-called atypical preeclampsia are not going to miss if you have this in your mind when you're investigating a patient with hypertension during pregnancy. So the pathophysiology in 1973, which was put up in the National Institutes of Health by the NIH, they put it up as it's primarily an ischemic disorder, and it affects the placenta, kidney, liver, and brain. And that was the pathophysiology then. But now the change is, it is more of a cellular immune response, which is having a pathology there, and that's contributing to preeclampsia. And the major cells which are involved in the pathogenesis are now thought to be in 2022 to be the regulatory T cells, the effector T cells, the NK cells, monocytes, macrophages, and neutrophils. So there's a change in pathophysiology which has been defined now to become more like immunological rather than ischemic. And when you talk about the pathophysiology of preeclampsia now, it is said it's because of an abnormal maternal immune response to the invading trophoblast of the placenta. This will cause a defective placentation. And this is usually driven by primiparity, a change in partner, and ovum donation fertility treatments. And that the pathophysiology is actually, risk factors have changed now compared to what was said earlier. So when there's a defective placentation, it's because of an impaired endovascular invasion of the spiral arteries in the uterus by the trophoblast. This will cause an ischemic change and then a reperfusion injury. And that happens because of the cellular oxidative or the endoplasmic reticulum stress. And when this injury happens and there's a stress pattern there, angiogenic factors are secreted into the maternal circulation, and you'll find abnormal levels of soluble FMS like tyrosine kinase, the SFLT1, and the placental growth factor. And when these two are abnormal, it will lead to an angiogenic imbalance. And when this imbalance happens, there's going to be the diffuse endothelial damage, and the change in the angiogenic factors is going to cause an increase in peripheral resistance. And when the kidneys get involved, there will be proteinuria. And the peripheral resistance, which is increasing, will go on to systemic hypertension. And there will be a change in the cerebral vasculature resistance. And vasospasm happens when the cerebral vasculature leads on to cerebral edema. The patient manifests with seizures with the symptoms of eclampsia. So the abnormal placentation, which can be because of predisposing factors like genetic factors, environmental factors, immunological factors, diet, and obesity, they will cause the abnormal placentation. And this abnormal placentation will cause a hypoperfusion of the placenta. There's ischemia of the placenta. The placenta is going to release factors such as SFLT1, which is going to block the angiogenic factors, vascular endothelial growth factor, and inhibit endoglin, and the TGF also gets induced. So they will have a diffuse endothelial damage, and there will be a decreased VGF and decreased TGF beta. So all this will contribute to resistance and hypertension. So, but there's now one change in the hypothesis. We always thought that preeclampsia is a primary placental disorder, in spite of not having any clear evidence. But now there's an emerging evidence that preeclampsia is not a primary placental disorder. It is actually a secondary placental dysfunction. And that they say it happens because the mother is already having a suboptimal maternal cardiovascular performance. And that will cause a decrease in the uteroplacental circulation. There's a hypoperfusion in the uteroplacental area. And because of the secondary dysfunction, it's going to contribute to the change in the angiogenic imbalance, change in the angiogenic balance, and that will contribute to hypertension. And there are now abundant studies in 2021 which have stated that cardiovascular dysfunction in the mother precedes the development of preeclampsia by almost several weeks or months. And they have given echo reports and testing of the vascular system to say that these changes happen in the mother even before she lands up with preeclampsia. So it's actually, they think now, the placenta is not the villain, it's now the victim. And the hypothesis points towards a primary problem in the maternal cardiovascular system, which is causing the placental dysfunction. And how do you manage severe preeclampsia when it happens? There are not much of changes, but this triad of management has to be done. You give, when there's a patient with severe preeclampsia, the blood pressure of 160 by 110, you will give her antihypertensives to control the blood pressure. Anticonvulsants are a must. Magnesium sulfate is the anticonvulsant of choice and should be given for any severe preeclamptic who comes to you. And if the baby is premature, corticosteroid should be given to improve the development of the baby's lung. And that is the SOGC guidelines as well as the WHO guidelines for management of severe preeclampsia. When you come to chronic hypertension, then you have to give hypertensives to maintain the blood pressure in the range of 110 to 140 by 80 to 85 diastolic. Give her antihypertensives, which can be nifedipine, hydralazine for severe hypertension, labetalol, oxypranolol, methyldopa, prazosin, and hydralazine. That's your choice. Ultrasound for the baby should be done from 26 weeks to identify a growth restriction and has to be done at 2 to 4 weeks interval. Always monitor the blood pressure and the urine protein in a mother who's got a chronic hypertension and induced labor term, which is well controlled. And that is from the American Hypertension Journals, which tells us the management of chronic hypertension. And the other change which has happened in the landscape is now there's a thought about the medium complications and the long-term repercussions of this disease and how do you prevent these problems. The importance is given for long-term implications because they are innumerable and sometimes irreparable. So the management has to start once a diagnosis is made, so the future is secured. And when a pregnancy is complicated by preeclampsia, we have to remember 20% of the women, the next 7 years will develop hypertension or microalbuminuria and may go on to have a chronic renal disease. And the same, but when you compare it to the lady who had no complications to a pregnancy, it's only 2% of these women will land up with complications. But when she's complicated by preeclampsia, almost 20% will go on to have problems of hypertension and microalbuminuria in the next 7 years. Similarly, there's a high risk of acute myocardial infarction, stroke, and venous thromboembolism in these women who had a personal history of preeclampsia. So these are the repercussions which are being thought about, and the prevention should start quite early. And there's a thought about the fetal effects of this disease also now. Neonatal complications we know happen because of prematurity, but some studies have already shown a negative impact on the neurocognitive development of these infants when they are evaluated in the first 2 years of life. So do not think that you'll save the baby and the mother. The complications may go on later into the neonatal time also. And the near-death experience of these mothers who develop preeclampsia and eclampsia has been given so much importance because there are so much psychological consequences suffered by the mother because of the disease. There's an emotional impact of this disease that involves anxiety, isolation, difficulties in feeding the baby, depressive disorders later in the life, and impairment of reproductive capacity. And the prolonged stays that these mothers have in intensive care units because of either the women herself or the newborn, and the physical or mental limitations to them may interrupt the natural order of symbiosis. The bonding between the mother and the baby may be damaged because of the near-death experience of mothers suffering from preeclampsia. And what are the preventive strategies that have changed over a period of time? Now we have changed from 75 milligram aspirin to 150 milligram aspirin based on the ASPRE trial. Now metformin has emerged as a target of studies for study of this disease in preeclampsia. And Pravastatin, the statins have been thought of as a good option to prevent preeclampsia. Proton pump inhibitors like esomeprazole is also being studied for prevention of this disease. And the ASPRE trial, the combined multi-marker screening and randomized patient treatment with aspirin for evidence-based preeclampsia prevention was designed to test the hypothesis that if there's a high risk for preterm preeclampsia, when you do a screening for these mothers, when you give aspirin at dose of 150 milligram per day, they wanted to know whether the incidence of preterm preeclampsia reduced. And this randomized trial showed that the administration of aspirin resulted in a significantly low incidence of preterm preeclampsia than the ones who had just placebo. So 150 milligram of aspirin in high-risk conditions will definitely prevent the incidence of preterm preeclampsia. And the other drug which has been studied for the prevention now is metformin. They say it reduces secretion of anti-angiogenic factors from the placenta in a dose-dependent manner. And it can also mitigate the endothelial dysfunction and can promote vasodilation in whole maternal or mental blood vessels when it was used. And in mice, when they used it, it was found to have angiogenic properties that can promote vessel growth from the aortic ring. So these are all evidence that metformin can be tried as a preventive modality for the prevention of preeclampsia. And the other drug which has been studied now, Pravastatin 20 milligram daily, and there are two big trials which are undergoing actually. The trial in Europe, that was the UDRA CT 2016 to 19, recruited 1,120 participants, but the recruiting is not yet over, and they have not stated the date of publication. The other trial, NCT, which is being 0394451 United States, has recruited 1,550 participants, and they're still recruiting, and the recruiting period is actually till 2031. And they found out that this drug, the basis for these studies was that this drug is known to have beneficial actions on both the placental and maternal vascular disease. And it was given in vitro. The administration of the drug to the placental tissues or cells upregulates the antioxidant pathways and can actually promote a favorable angiogenic profile by decreasing secretion of SFLT and S-endoglin. So there are a large number of trials which are underway, and these two are the big trials. And when they come into the picture, probably it will give us an idea like we can use one more drug other than aspirin to prevent preeclampsia. And the proton pump inhibitors, lansoprazole, rabeprazole, and esomeprazole, are known to decrease the placental release of SFLT and SNG in vitro. And actually, it happens at lower concentration than the statins. And they're known to reduce placental and vascular pro-inflammatory cytokine production and can mitigate the endothelial dysfunction. They can also facilitate a favorable vascular dynamic as it upregulates phosphorylated nitric oxide synthase in endothelial cells and probably improve the vasodilatation and help in the management of this disease. And what is the change in the prediction of preeclampsia that has happened over the decades? Earlier, it was the pyramid proposal for prenatal care, but now it's a new inverted pyramid proposal for in your prenatal care. Here, all the efforts need to be concentrated in the first trimester to identify this disease so that you have an earlier diagnosis and you can put up therapeutic proposals established even in the subclinical stage of aggravation of this disease. So when the disease is fully established, it's very difficult to manage. So you need to start your investigations in the first trimester, diagnose it early, put up the therapeutic proposals even before the whole disease is manifested so that you manage it even at the subclinical phase. And the next change which has happened is when they've differentiated this disease depending on the moment of manifestation. If it happens before 34 weeks of pregnancy, it is now called as early onset preeclampsia. And when it happens after 34 weeks, it becomes a late onset preeclampsia. And it's totally different. The placental damages and the phenotypes are quite different between the two types of the disease. In early onset, you will have a lower placental volume. It is because the vascular lesions predominate in the early onset preeclampsia. It is more associated with placental insufficiency and a growth restriction of the baby. But when it happens after 34 weeks, actually you will see signs of chronic inflammatory response. It's not the vascular lesions you see, and it will be associated with the milder clinical conditions, and the placenta will be of normal volume. It will not be low as in an early preeclampsia. And that's because we have to differentiate between these two types of preeclampsia because there are different damages happening to the placenta and the phenotypes are quite different. And what is the difference in the risk factors between early onset and late onset? You will see that early onset preeclampsia happens more in multigravidas. And when they have chronic hypertension and a past history of preeclampsia, you have to be ready for an early onset preeclampsia in this pregnancy. And this is based on an 18-year observational cohort study. And late onset preeclampsia is common in primipara, a lady who's above age 35, and when she's a higher BMI, a BMI more than 35, will contribute to a higher risk of late onset preeclampsia. But there's one important fact they found out. Diabetes was not an independent risk factor, neither for early onset preeclampsia or late onset preeclampsia. That was a surprising finding. And what about the age and onset of preeclampsia? Rising maternal ages are actually associated with both early onset and late onset, while increments of BMI, that is obesity, is more associated with late onset preeclampsia. And what about BMI and late onset preeclampsia? They are specifically associated with late onset. And this may explain the discrepancy we are seeing in different countries. In high-income countries, more of preeclampsia or late onset, and that is basically probably because of the BMI and diabetes, which is there in high-income countries compared to medium to low-income countries where it happens more in primiparas, and it happens 60 to 70% will be the late onset is only 60 to 70%, but in 90% of preeclamptic case in high-income countries will be late onset preeclampsia. And when you talk about the weight of the mother, the risk of preeclampsia doubles with each 5 to 7 kilogram per meter squared increase in the pre-pregnancy weight. A lady who enters pregnancy with a high BMI is going to have a higher risk of preeclampsia. And the mechanisms have not been totally explored. They only partially explored, and they say maybe because of an increased cytokine-mediated inflammation and an oxidative stress, probably an increased shear stress, a higher chance of dyslipidemia, and then there's an increased sympathetic activity, which has been proposed as possible pathways. The problem of maternal corpulence is actually interesting in preeclampsia because it tells a changing landscape of this disease. In the earlier decades, in 1950, 31, 52, Davis, and all these textbooks never mentioned that overweight and obesity is a risk factor for preeclampsia, but now it's almost like a tsunami. Those years, probably obesity was not an enormous public health problem. Now it's an epidemic, and it started around the year of 1975. And the interest in the effect of obesity as a risk factor of preeclampsia has been raised in the beginning of 1990s, and the beginning of the 21st century is almost like a tsunami. So maternal corpulence and increasing BMI is increasing the higher risk of preeclampsia in our mothers now. There was a study which was done in 2014, and they took 2,637 women in this analysis. And they found out when a patient is overweight or obese, this was the most important risk factor for both preeclampsia and severe preeclampsia, with the attributable risk percentage of almost like 65% for both overweight and obese women landing up with a complication of preeclampsia and severe preeclampsia. It's so important now. What about ART treatment is contributing to an increase in preeclampsia? According to the study in 2019, it has caused an increase of almost 1.71-fold in preeclampsia. And the reasons why assisted reproductive technologies are contributing to preeclampsia is there is an abnormal placentation in ART pregnancies. In some ART procedures, the blood flow is compromised because of the procedures and the drugs. And when it's diminished, it's going to cause more of obstetric complications. And it can also happen because of a placental insufficiency, because of an altered hormonal endometrium, because you give the load the patients with estrogen and progesterone, and probably that causes an insufficient in the placenta. And it has also been argued that assisted reproductive technology may cause epigenetic effects in the placenta and the fetus, and that may contribute to an increase in risk of preeclampsia. What about donor gametes, which are contributing to preeclampsia? When the mother conceives through donor oocytes, there's a higher risk of preeclampsia. Here, the placenta may not be the villain. The role of the maternal immune reactivity towards a foreign gamete, that is a foreign fetal antigen, may play a role in the higher incidence in donor gestations. And remember, there's almost a 25% of preeclampsia in donor gamete pregnancies. And that's why donor gametes being used for pregnancies in older mothers have to be taken with a pinch of salt. What about frozen cycles? Artificial FET cycles have got an increased risk of preeclampsia in comparison with natural and stimulated cycles. In frozen cycles, you do not have the corpus luteum, and that may contribute to the observed increased risk of preeclampsia. The corpus luteum is known to secrete vasoactive hormones like relaxin, which are not replaced in artificial cycles where you give just estrogen and progesterone. This may compromise a maternal cardiovascular adaptation to the pregnancy, resulting in an increased risk of preeclampsia. What about recurrent miscarriages and the association with ART? The pregnancies from ART are associated with preeclampsia through oxidative stress. And when you see the patient with recurrent miscarriages, there is also a similar pathology there, more of oxidative stress that's contributing to miscarriages. So when you have an infertility treatment for a patient who's got recurrent spontaneous miscarriages, there's a tremendous increase in the risk of preeclampsia in comparison to those without treatment. That was a study in 2015. So in recurrent preeclampsia, the rates have increased over the past 2 decades. It's not decreased at all, in spite of so much of diagnosis, management, and all that. And this is maybe because of the increase in diabetes mellitus, obesity, and chronic hypertension in our mothers. And that's why the rate of recurrent preeclampsia has increased so much. And when the patient has had a previous preterm delivery because of preeclampsia, or she has undergone a cesarean delivery because of preeclampsia, there's a higher risk of recurrent preeclampsia. So any complication of the previous pregnancy, please remember, there's a higher risk of recurrent preeclampsia in this pregnancy also. So what are the reflections on advances in preeclampsia research over 2 decades? And this has been brought about the 11th workshop in immunology of preeclampsia in Reunion 2018, which celebrated its 20th year, the 20th candle. all the members of the workshop, they reflected on the main tracks during which has happened in 2 decades of research on this disease. And the first reflection they had was the advance in immunology of reproduction, the field of preeclampsia, which was poorly developed 2 decades ago. So immunology has developed, and that's why the understanding of the disease has increased. The second reflection which this group had was, why does preeclampsia exist in humans? Because in an evolutionary point of view, there is no established natural animal model in almost like 4,000 other mammal species which do not have this disease at all. The third reflection which this group had was the biological plausibility of preeclampsia disease of first pregnancies at a level of a couple. That is, remember that primary paternity is the one which corresponds more with preeclampsia more than primary gravida. And that's why that paternal-maternal conflict, the immunology part of it, is not being fully understood still. But there's an apparent conundrum because the human species should have disappeared because more than 40 to 50% of this diseases, hypertensive disorders in pregnancy, happens in couples who conceive in the first 4 months of sexual cohabitation. So actually this disease should have died and the human species should also have disappeared. The final reflections of this group was the main difference between early onset and late onset preeclampsia. The early onset is because of immunological problem, and the late onset is because of maternal vascular predisposition, which is not good for the pregnancy. And the debate of why high-income countries report almost 90% of the preeclampsia being late onset, while other countries describe epidemiologically very high incidence of early onset preeclampsia. This debate is still going on. And the final thought of this group was the pathophysiology of this reversible systemic maternal vascular inflammation, which disappears after delivery of the baby. So when you talk about early onset and late onset preeclampsia, the concept which has been accepted now is there's a failure of trophoblastic invasion and the adaptation of the uterine spiral arteries, which leads to relative placental ischemia in early onset. Whereas in late onset, it's because the increased maternal susceptibility to the vascular and the metabolic stress of pregnancy is a reason for late onset, or maybe because an advance in placental senescence, which will release damaging vasoactive factors late in pregnancy, causing late onset preeclampsia. So I want to conclude this talk, which can never be concluded because the disease, the understanding of this disease is still not fully known to everybody, but the landscape is totally changed. The pathophysiology has been defined, but we are still not there. Proteinuria is not an essential condition to characterize preeclampsia now. There's a change in trend. The developed countries have more of late onset preeclampsia. The developing countries have more of early onset preeclampsia. The risk profile has totally changed. The mothers being older, higher corpulence, increase in BMI, and use of assisted reproductive technology has increased the incidence of this disease. And there's now a proposed theory of change in placenta being the victim rather than the villain. And the long-term repercussions of the disease are being taken quite seriously now. The fetal effects and the psychological effects of the mother are being highlighted. I'd like to thank AMOGS, Dr. Pardeshi sir, Dr. Sujata ma'am, Dr. Bharati, and a special thanks to Dr. Pratik Tambe for the opportunity. Thank you so much.
Thank you, Dr. Charmila, for giving us absolutely changed landscape so far as hypertensive disorders are concerned. We always thought that abnormal placentation was at fault, but then we realized that it's an immunological factor which is responsible for abnormal placentation, which in turn leads to hypertensive disorders. Proteinuria, we always thought was very important so far as preeclampsia was concerned, but now the concept has changed that even if you have hypertension without proteinuria, what we need to look after is multiple organ dysfunction, which needs to be more or less looked after rather than only going behind the proteinuria part of it. And secondary placental dysfunction was mainly after the cardiovascular dysfunction of the female. So we need to look after the cardiovascular dysfunction just to find out that maybe the patient could have a preeclampsia later on during the course of the pregnancy. So far as management is concerned, it's more or less remained the same. More stress on hypertensive disorders than on magnesium sulfate so far as preventive eclampsia, and of course steroids. There's something what she spoke about was early preeclampsia and early onset and late onset preeclampsia. In developing countries, you find early onset preeclampsia as compared to the one in the developed countries, you find late onset preeclampsia. And so far as prophylaxis is concerned, we always harp on the aspirin. Aspirin remains as the forefront, but we do have now other molecules which are being studied like metformin, like statins, And third more, I think proton pump inhibitors. So maybe a few years from now, we could have one of these drugs also helping us so far as prevention of preeclampsia is concerned. And last thing, more stress has to be put on the first trimester to predict the possibility of preeclampsia. And in case you find that the patient have some predictability so far as preeclampsia is concerned, start off with the prophylactic treatment so that she doesn't develop preeclampsia or PIH later in the third trimester. Okay. So thank you so much, Charmila, for giving us a different landscape so far as hypertensive disorders or preeclampsia is concerned.
Thank you, Dr. Charmila and Dr. Sujata, Madam. Pardeshi, sir, any comments before we move on to the next talk? We'll take the questions at the end of the session.
It was a really excellent talk by Charmila. As usual, she is all-rounder and she has given all insights of the hypertensive disorders. Thank you, Dr. Charmila.
Thank you.